welcome to the deep dive. Today, we're tackling a really significant area in modern healthcare, providing essential wound care for bariatric patients.
It absolutely is. It's a field that's, well, becoming impossible to ignore given the dramatic shifts we're seeing in population health.
Exactly. And to get right to the core of this, we've immersed ourselves in wound care essentials, practice principles, specifically the chapter focusing on adiposity in the bariatric patient. Think of this as your streamlined guide to understanding the crucial healthcare considerations for this growing patient population. Our goal is really just to pull out the most vital insights for you.
Yeah, our mission is pretty straightforward: to equip you with a clear understanding of the unique healthcare needs of bariatric patients.
Okay.
We'll focus on, maintaining their skin health, preventing pressure injuries, and navigating the challenges that healthcare facilities are facing in this evolving landscape.
Okay, let's unpack this. The chapter immediately grabs your attention by highlighting a powerful trend. The number of individuals in the U.S. and really across the globe who are classified as overweight or obese has increased dramatically.
It's huge.
We're talking about more than 2/3 of adults just in the States, and a notable segment, maybe between 3 and 10%, are now categorized as morbidly obese.
And what's particularly striking is the acceleration, how fast this is happening. Morbid obesity rates have essentially quadrupled since the 1980s.
They quadrupled, wow.
Yeah. And the data suggests a concerning trajectory. Those who are already in the highest weight categories are, on average, just becoming even heavier.
So it's not just more people, but the severity is increasing too.
Exactly. This isn't just about more people being heavier. It signals a real rise in the complexity of their health needs and the increased physical demands on our healthcare systems.
Right.
It really necessitates a rethinking of how we design our care environments and, train our staff.
It really underscores why healthcare facilities need to be proactive and adapt. Which, leads us to the term bariatrics. For those who might not be familiar, this is the branch of healthcare specifically dedicated to the treatment of obesity and its associated conditions.
And it's crucial to acknowledge that the term obesity itself, it carries different connotations depending on who you ask.
That's a good point.
The American Society for Metabolic and Bariatric Surgery, they define it medically. It's seen as a lifelong progressive condition involving excessive fat storage and numerous related health problems.
Okay, the medical view.
But then conversely, you have groups like the National Association to Advance Fat Acceptance, or NAFA. They view it more as a natural human variation, not something inherently negative.
That difference in perspective is so important, isn't it?
It really is.
It highlights the necessity for healthcare to be rooted in compassion and focused on achieving the best possible outcomes for each individual.
While respecting their needs and perspectives, yeah.
The authors make a really insightful comparison here, drawing parallels with pediatrics.
Oh, interesting. How so?
Well, just as we have tailored policies and equipment for children of all sizes, we need to adopt a similarly size-sensitive approach for bariatric patients.
That makes a lot of sense. So it's not just about bigger beds.
Yeah, exactly. So I wonder, beyond just equipment sizing, are there parallels in how we communicate? Maybe focusing on development and milestones in their health journey, sort of like pediatric care.
That's a fascinating point. Connecting this to the bigger picture, it emphasizes that healthcare systems need to go beyond just having larger equipment.
Right.
It requires a fundamental shift towards implementing size-aware policies across the board, making sure staff get the right training, and providing, comprehensive support to deliver truly optimal and respectful care.
So how do healthcare professionals actually categorize bariatric patients?
Yeah.
It's clearly not a one-size-fits-all situation.
Precisely. And that's key. There are several recognized ways to define and classify obesity in healthcare settings.
Okay.
These include things like a person's overall body weight, their body mass index, or BMI.
The classic one.
Yeah, the classic one. Also, the way their weight is distributed on their body, that's crucial. Whether their weight impacts their ability to move, and even if it presents practical challenges for healthcare professionals trying to provide care.
So BMI is just one piece of the puzzle.
Exactly. While BMI is a useful starting point, it definitely doesn't tell the whole story, especially for bariatric patients where body composition and fat distribution play such a critical role in things like skin health.
And BMI, of course, is that calculation based on height and weight. The chapter outlines the National Heart, Lung, and Blood Institute classifications, starting with overweight at a BMI of 25 to 29.9, then moving through Class 1, Class 2, and the more significant Class 3 obesity, which is a BMI of 40 or higher.
And while BMI gives us that quantitative measure, the authors rightly emphasize that the qualitative aspects, how the body is actually composed, are also incredibly important.
Especially for skin integrity and pressure injury risk. Which brings us neatly to the concept of body weight maldistribution. This is where we talk about the apple versus pear body shapes, right?
Exactly that. Someone with a pear-shaped weight distribution carrying more weight around their hips and legs.
Okay.
They might face a higher risk of developing pressure injuries on their buttocks and might need specialized seating, special commodes, that kind of thing.
Makes sense. And then the apple shape, where more weight is concentrated in the upper body, greater waist-to-hip ratio.
Yeah.
That presents a different set of considerations.
Yes, absolutely. That particular distribution is often associated with a higher risk of cardiovascular and respiratory complications.
Breathing issues.
Yeah. So for these patients, proper positioning becomes absolutely critical to help ease the pressure on their respiratory system.
Okay.
The chapter even mentions an increased risk of skin breakdown around a tracheostomy site because of excess tissue in the submental area, under the chin for those with this upper body weight distribution.
Wow, that's specific. There's a really helpful visual in the chapter, figure 24:1, which clearly shows these apple and pear shapes and the differences in waist-to-hip ratios.
Yeah, those visuals are great.
It really drives home the point that the potential health risks can vary significantly among bariatric patients depending on how their weight is actually distributed.
And this inherent variability, it just underscores the critical need for healthcare facilities to be truly prepared.
Prepared for anything.
Pretty much. Prepared to address a wide spectrum of patient needs. This includes having established bariatric skincare protocols in place and ensuring easy access to specialized equipment.
Like appropriately sized beds, chairs, commodes, walkers.
All of it.
The chapter also provides a list of common health conditions that these patients might present with upon admission. It's quite extensive.
It often is. Things like hypertension, type 2 diabetes, coronary artery disease, sleep apnea, various skin manifestations, the list goes on.
And it's vital to remember that these pre-existing conditions can significantly complicate their overall care, right? And elevate their risk for developing additional health issues.
Absolutely. And the chapter also touches upon a sensitive but important point. Patients might hesitate to seek medical treatment.
Because of embarrassment.
Yeah. Due to feelings of fear or embarrassment related to their weight, which can unfortunately lead to poorer clinical outcomes down the line.
That really highlights the importance of creating a welcoming and sort of destigmatizing healthcare environment for these individuals.
Couldn't agree more.
It really makes you consider how prepared healthcare institutions truly are. Like, are emergency departments equipped to handle the specific, often urgent needs of bariatric patients?
Good question.
Are staff members adequately trained not only to provide safe and effective care, but also to do so with respect, and while protecting themselves from potential injuries?
These are fundamental questions. Every healthcare facility needs to address them proactively. The chapter effectively highlights the complex interplay of existing health conditions, the potential for slow-healing surgical wounds, the increased likelihood of venous disease and pressure injuries.
Plus diabetes-related foot wounds.
Right, and various nutritional concerns, all with a central focus on thorough skin assessment and maintaining skin integrity.
Okay, let's delve deeper into the specifics of that skin assessment. The chapter emphasizes that for bariatric patients, a simple visual check just isn't enough.
That's absolutely correct. Because of the unique physiological characteristics like a larger skin surface area relative to weight, the presence of redundant skin folds often compromise blood flow and adipose tissue.
Right, the fatty tissue.
Exactly. Their skin is particularly vulnerable and requires a much more comprehensive evaluation.
So what exactly does a thorough skin assessment involve in this context? How do you do it right?
Ideally, it should be conducted upon admission. The patient should be in a gown, lying flat in bed if they can comfortably tolerate that position. The crucial step is to gently separate and carefully examine all skin folds. Look for any signs of redness, moisture, areas of skin breakdown, or pre-existing pressure injuries.
And I imagine getting into those folds can be tricky.
It can be, because these areas can sometimes be difficult to access and might cause discomfort. This often requires the assistance of 2 or more healthcare professionals. Safety first for everyone.
Right. And these skin folds tend to occur in predictable areas, don't they? Like behind the neck, under the arms, beneath the breast.
In the abdominal area, especially the paniculus along the flanks, in the perineal and rectal regions, upper and lower thighs, even down to the calves and ankles.
Figure 24-2 in the chapter gives a really clear illustration of those key areas. It's helpful to visualize.
It is. And it's also vital to remember that even after bariatric surgery, any remaining excess skin can still create these problematic folds.
Oh, good point. So the need for assessment doesn't just disappear after surgery.
Not at all. These patients continue to require thorough skin integrity assessments whenever they're admitted for any healthcare need.
Now, the chapter specifically mentions the paniculus or panis. Can you explain to our listeners what that is?
Sure. In simple terms, the paniculus or panis refers to an accumulation of fatty tissue in the lower abdominal area. It often results in a significant overhang or skin fold.
Okay. Figure 24-3 shows that visually.
Yeah. And to help with assessment and care planning, there's a recognized grading scale for the panis. It ranges from grade 1, where the fold just covers the pubic hairline,
Okay.
all the way to grade 5, where it extends down to the knee and sometimes even below.
Grade 5, wow. That must present significant challenges.
Huge challenges. A grade 3 panis, for example, extending to the upper thigh, significantly limits mobility and makes thorough skin assessment and hygiene much more difficult. It often requires specialized techniques and extra staff.
That's a considerable range.
Yeah.
And as the chapter points out, the combination of pressure between these skin folds and trapped moisture, that can lead to some significant complications.
Exactly. These conditions create an environment ripe for problems. It can contribute to the development of deep tissue injuries, pressure injuries, and something called intertriginous dermatitis, or ITD.
ITD? Yeah.
Figure treble 4 actually shows an example of a grade 5 panis with associated ITD. So ongoing assessment and implementing appropriate preventative and treatment strategies are absolutely critical in these cases.
And the chapter references the 2019 guidelines from EPOP, NPIA, and PTPIA.
Right, the major pressure injury advisory panels, they offer specific recommendations for assessment and positioning of bariatric patients to help mitigate these risks.
Okay. Moving on to some of the specific skin conditions that tend to be more prevalent in bariatric individuals.
Yes.
Acanthosis nigricans is one that's highlighted.
Yes, Acanthosis nigricans. It typically presents as dark, velvety, often thickened patches of skin, usually in body folds and creases, like the armpits, groin, back of the neck.
Velvety texture.
Oh, yeah. The texture can initially be soft, but might become rougher over time. It's frequently associated with conditions like obesity, insulin resistance, diabetes, other endocrine disorders.
It's like a visual marker.
It can be, yeah. A red flag for underlying metabolic issues that can significantly impact wound healing later on.
And while treatment often involves addressing the underlying cause, like weight management or controlling blood sugar, there are also topical treatments.
Correct. Topical creams, antibacterial soaps, sometimes even laser therapy can help improve the appearance and texture of the affected skin.
Okay. Then there's plantar hyperkeratosis.
Right, that's basically a thickening of the skin on the soles of the feet, particularly in weight-bearing areas. It's another common issue related to the increased mechanical stress from carrying excess weight.
And the treatment is fairly intuitive.
Pretty much. Weight loss helps reduce the stress, and using orthotic shoe inserts can provide cushioning and support.
The chapter also discusses stasis dermatitis, which primarily affects the lower legs.
Yes, stasis dermatitis is an inflammatory skin condition. It develops because of poor circulation in the veins of the legs, often seen in individuals with obesity or a history of venous insufficiency.
What does it look like?
It can manifest as redness, scaling, itching, dry or shiny skin, and the appearance of reddish-brown patches. In more chronic or severe cases, the skin can become tight and scarred. It can even lead to skin breakdown, weeping, and ulceration.
Figures 24-7A and B show examples of that. So the increased weight and potential for venous insufficiency in bariatric patients kind of create a perfect storm for stasis dermatitis in the lower legs.
That's a good way to put it, yeah.
And then there's Charcot foot, which has a higher occurrence in individuals with morbid obesity who also have diabetic neuropathy. That sounds particularly serious.
It is very serious. Diabetic neuropathy can cause nerve damage, leading to a loss of sensation in the feet.
So they can't feel injuries.
Exactly. Because of this reduced feeling, patients may not notice minor injuries. The bones and joints in the foot can weaken and even fracture without them realizing it.
Oh, wow.
Over time, this can lead to a significant change in the shape of the foot, often described as a rocker bottom deformity. Figures 24-8A and B illustrate those changes quite starkly.
Yikes. Finally, the chapter touches on cellulitis, a bacterial skin infection.
Right. A relatively common but potentially serious infection. It typically presents as an area of skin that is swollen, red, painful, and warm to the touch.
Usually lower legs.
Most frequently on the lower legs, yeah, but it can occur anywhere on the body. It usually develops when bacteria enter through breaks in the skin. Figures 24 to 9A and B show what that can look like.
Okay, let's turn our attention now to moisture-associated skin damage, or MASD, specifically intertriginous dermatitis, ITD. This seems particularly relevant for bariatric patients because of all those skin folds we talked about.
Absolutely. ITD, sometimes just called intertrigo, is indeed a type of MASD. It arises when moisture gets trapped in skin folds, leading to inflammation.
Inflammation?
Yeah.
And potentially infection.
Yes, the inflammation can be further aggravated by the presence of bacteria, fungi, or even viruses. A hallmark characteristic of ITD is its mirror image presentation,
Meaning?
meaning the affected skin surfaces within the fold show similar patterns of irritation, like looking in a mirror.
Got it. And the increased risk for obese patients is pretty clear given the greater number and depth of skin folds.
It is. The chapter even cites survey data suggesting that a significant majority, like 63% of obese patients, reported experiencing more than one skin-related problem. Broken skin and itching were the most common.
What's fascinating here is a combination of factors that contribute to ITD.
It's multifactorial, definitely. You've got moisture from various sources, perspiration, urine, feces, wound drainage, even mucus accumulating in skin folds.
Leading to maceration, right? Skin softening.
Exactly, maceration. Then you add the constant pressure from the skin surfaces within the fold, rubbing together friction and shear forces from movement.
Plus, challenges maintaining hygiene in those areas.
Right. And the warm, dark, moist environment creates an ideal breeding ground for microbes.
And if it's untreated?
Untreated ITD can escalate to more serious infections, like cellulitis. Figure 2410 illustrates that potential progression.
And ITD can occur in lots of places where skin folds are present. Under breasts, abdominal folds, armpits.
Folds of the neck, groin, perineal areas. And the chapter also points out that factors like prolonged bed rest, immobility, fever, and using certain meds like antibiotics or steroids can further increase the risk.
So with all these contributing factors, prevention really becomes the cornerstone of managing ITD in bariatric patients.
Absolutely. Prevention is key.
What are some of the key preventative strategies outlined in the chapter?
Well, the primary focus is on keeping the skin clean, thoroughly dry, and well supported. This minimizes the damaging effects of moisture, pressure, friction, and shear.
How do you keep it clean and dry effectively?
The chapter recommends using gentle, pH-balanced soaps or no-rinse cleansers. Then, careful and complete patting of the skin, not rubbing, to ensure it's fully dry.
Okay, patting dry. Makes sense.
And because moisture accumulation between folds is an ongoing challenge, even between bathing.
Yeah, it doesn't just stop.
Right. So using soft absorbent materials like linen cloths or non-occlusive, high airflow incontinence pads placed between the folds can be really beneficial.
How do those help?
They help to offload pressure, absorb excess moisture, and reduce friction. The chapter even highlights the successful use of fabrics impregnated with silver. Figure 2411 shows this for their antimicrobial properties.
Silver fabrics, interesting. Appropriate clothing choices also seem to play a role.
They do, ensuring well-fitting, non-synthetic bras for women with larger breasts, for instance, even considering supportive garments for men with significant breast tissue.
Right, and the chapter emphasizes frequently changing any absorbent materials placed between skin folds, especially if they get damp.
Crucial. Gotta keep it dry. Proper positioning in bed is another key element.
How so?
Ensuring the paniculus is adequately supported with pillows, placing a pillow between the knees. These things help promote airflow and reduce skin-on-skin contact.
And special beds?
Yeah, using low air loss beds or beds with integrated microclimate control features can also really help in keeping moisture levels down in these at-risk areas.
Okay, that covers prevention. What about when ITD does develop? What are the recommended treatment approaches?
Treatment strategies are really guided by the underlying cause, what's driving the ITD.
Okay.
If a fungal infection like Candida is suspected, topical antifungal meds are typically used. In more severe or widespread cases, systemic antifungals might be necessary.
And bacterial infections?
Topical or systemic antibiotics, particularly if there's no improvement with initial measures or if complications like cellulitis are present.
What if it's more inflammatory?
For inflammatory conditions like atopic or contact dermatitis contributing to the ITD, topical or sometimes systemic corticosteroids might be prescribed.
Anything else?
The chapter also mentions using Burow's solution, which contains aluminum acetate, as soaks or compresses to help soothe inflammation and promote drying.
It's interesting that the chapter points out the persistent challenge of ITD even after significant weight loss.
Because of the redundant skin, right?
Exactly. That excess skin can still trap moisture and cause friction. In these situations, surgical interventions like paniculectomy or other body recontouring procedures might ultimately be considered.
Now let's transition to the critical area of pressure injury prevention, keeping in mind the specific, often heightened risks for bariatric patients.
A huge topic.
We're familiar with the general principles of pressure injury prevention, but what are the key differences and additional considerations for this population?
Well, the chapter highlights that the way pressure is distributed across the body differs somewhat in obese individuals,
How so?
unlike non-obese individuals lying flat, where pressure is mostly concentrated over bony prominences.
Right, like hips, heels, sacrum. Exactly. Bariatric patients tend to experience a greater overall weight-induced force distributed across their entire posterior body surface.
Does that mean standard pressure relief strategies focused just on bony prominences might be less effective? Do we need to rethink that approach?
That's a very insightful question. While pressure remains a significant concern over bony prominences, it's also notably elevated in soft tissue areas like the buttocks in bariatric patients. Figure 2412 visually illustrates this difference.
Okay.
Plus, that maldistribution of weight we talked about earlier adds another layer of complexity. It really emphasizes the need for a highly individualized approach to risk assessment and prevention.
So what are some of the characteristics or locations where pressure injuries might be more likely to develop in bariatric patients compared to the general population?
Well, while they can certainly occur over the traditional bony prominences, we also see them developing in those high soft tissue pressure areas like the buttocks. Bilateral pressure injuries on the hips are also more common, often seen in patients who've been seated in chairs that are just too narrow for their hip width.
Equipment sizing again.
Always crucial. Additionally, there's a heightened risk of pressure damage caused by medical devices themselves.
Like tubes.
Yeah, various types of tubing, oxygen delivery devices, even tracheostomy ties if they're applied too snugly.
Wow, you really have to think about everything.
You do. It emphasizes the need for heightened awareness of these seemingly innocuous sources of pressure.
Given these unique factors, are there specific subscales of the Braden scale, for instance, that are less reliable or need a different interpretation for bariatric patients?
That's a good point the chapter touches on. While the Braden scale is still important as a general screening tool, you really need to explore the subscales fully and consider the whole clinical picture, not just the score.
It does seem like a more nuanced approach is needed. However, the chapter also points out that many obesity-related pressure injuries are indeed preventable.
They are. Through comprehensive risk assessment, the consistent use of appropriately sized bariatric equipment, proper application of that equipment, and diligent, frequent skin inspections.
The chapter also briefly touches on deep tissue injury, or DTI. Is there any indication of a potentially higher risk for DTI in bariatric patients?
There is some clinical speculation, yeah, that the incidence of DTI might be higher in obese patients due to the deeper and more sustained pressure on tissues.
So what does that mean for assessment?
It means during skin assessments, it's particularly important to be vigilant for those subtle early signs of DTI. Slight discoloration of the skin, changes in temperature, changes in tissue consistency or firmness.
And if DTI is suspected?
Immediate priority, completely offload pressure from the affected area, get the pressure off.
The chapter provides some really practical questions to consider when developing a care plan. Like, for a patient on bed rest, how do you position them for breathing without causing shear? Should you use pillows under arms? Would a trapeze help? Is the bed wide enough? What about nutrition?
These are all absolutely vital considerations, every single one. And if there's a risk of incontinence-associated dermatitis, is there easy access to a bariatric-sized bedside commode or walker to help with timely toileting?
Right.
For patients with limited mobility, are appropriately sized patient lifts and slings readily available? Are there enough staff trained to use them?
These questions really underscore the importance of proactive, thoughtful care planning that addresses the specific needs of bariatric patients.
Absolutely.
Which naturally leads us to the crucial topic of bariatric equipment. It's clearly more than just having larger versions of standard stuff.
Oh, much more. There are significant considerations around safety, patient safety, and caregiver safety, accessibility for the patient, staff sensitivity in using and discussing the equipment, the need for specialized technology, even having enough staff to safely operate everything and assist the patient.
Seems like a facility needs a plan.
Definitely. The chapter rightly emphasizes the importance of conducting a facility-wide readiness survey to verify the weight limits of all patient-related equipment, Chairs, beds, commodes, lifts, everything.
Yeah. And the chapter makes a good point about discreetly labeling equipment with its weight capacity, using codes like EC500 or U500, clear to staff, but not stigmatizing for patients.
Yeah, that sensitivity matters. Even seemingly small details like checking if floor or wall-mounted toilets are adequately reinforced to support higher weights are important.
You wouldn't necessarily think of that.
You might not. And considering doorway dimensions for passing larger equipment and for patient ambulation, elevator weight and size limits, these are all critical logistical considerations.
For safety and just a positive patient experience.
Exactly. And having appropriately sized personal items, gowns, blood pressure cuffs, it's not just comfort. It's essential for dignity and for accurate, safe care.
When specifically considering bariatric beds and chairs, what are some key questions providers should ask?
Okay, so, is the bed frame width adequate? Can it be adjusted or expanded? Can the patient reposition themselves without hitting the side rails? What's the safe working load?
Right, the weight capacity.
How might the patient's specific weight distribution, apple versus pear, impact the need for head and foot elevation features? Is a load-tested trapeze available?
Does the mattress surface help with moisture?
Good one. Does the therapeutic support surface offer features for moisture control and microclimate management? Airflow features. Is the bed designed to help the patient get out of bed safely and promote early mobility?
And for chairs?
Same idea. Are wheelchairs and other seating options sufficiently wide and way-rated for the patient's needs?
The chapter also addresses the concerns and safety of the healthcare staff, which is absolutely paramount. It references the ANA's Safe Patient Handling and Mobility Standards.
Yes, the SPHM guidelines. They really highlight the strong emphasis on protecting caregivers from injury.
Which seems even more critical here.
It's such a critical aspect. Caring for bariatric patients often involves increased physical demands. So ensuring the right equipment, bariatric lifts, air transfer devices is readily available is crucial.
And that staff know how to use it.
Absolutely. Staff need to be thoroughly trained in their safe and effective use to prevent work-related injuries. Comprehensive education is vital to build staff confidence and ensure high-quality care without compromising their own well-being.
And the chapter emphasizes that repositioning bariatric patients is really a blend of protocols and individual needs, like an art and the science.
Precisely. It requires a coordinated effort by a trained team, and whenever possible, involving the patient in the process helps maintain their mobility and respects their dignity.
Listening to the patient and family.
Definitely. Their suggestions and preferences can often be invaluable. Implementing consistent repositioning protocols for those who can't reposition themselves, considering individual tolerance, using appropriate tech to minimize friction and shear, these are all key.
And small shifts help too.
Yeah, even small, frequent shifts in body weight can be a helpful adjunct to regular turning schedules and promoting skin health.
Finally, let's discuss the importance of offloading heels in bariatric patients. The chapter notes that heels are particularly vulnerable due to potentially compromised circulation.
Heels are indeed at significant risk. They should be completely off the bed surface.
How do you achieve that?
Supported by pillows placed under the calves, being careful to avoid pressure on the Achilles tendon, or by specialized heel offloading positioning devices.
But patient anatomy varies, right?
It does. It's important to take into account the patient's individual lower extremity anatomy. Factors like large calves might naturally create some heel suspension.
So you have to check.
Yes. The key is to palpate carefully under the heel and lower leg to identify any areas of high pressure and then redistribute weight effectively using pillows or positioning aids.
And make sure the devices fit properly.
Crucial. Ensure any heel positioning boots or devices are correctly sized and aren't creating new areas of pressure. The ultimate goal is even pressure distribution, not just shifting it around. Subjective analysis of the pressure footprint in different positions can be really informative.
Okay. So to bring it all together, this deep dive into the chapter on adiposity and the bariatric patient clearly demonstrates that the increasing prevalence of obesity necessitates a comprehensive, proactive, and highly specialized approach to wound care for these individuals.
Absolutely. It demands a thorough understanding of their unique physiological risks, the consistent implementation of preventative strategies, the appropriate use of specialized bariatric equipment, and a strong commitment to ensuring the safety and well-being of both the patients and the healthcare staff.
It really underscores the critical importance of pre-planning, conducting targeted and thorough assessments, utilizing the right technology, and providing ongoing education and training.
all to ensure that we are delivering respectful, individualized care that ultimately leads to improved patient outcomes and, importantly, a safer working environment for healthcare professionals.
Yeah, worker safety is huge, too.
Which raises a really important question for you, the listener, to consider. Given the rapid advancements we're seeing in bariatric care, what further innovations in technology and clinical protocols do you anticipate will be the most impactful in the coming decade?
Good question.
Both in terms of enhancing the well-being of bariatric patients and the safety of their caregivers, it's a continually evolving area, and our ability to adapt and innovate to meet the diverse needs of all patients will be paramount.